I'm really excited to be here today to talk about our Community First Responders program. I got the text message at 5 o'clock last night that I was going to be speaking today. But I'm super excited, and I've brought lots of things, lots of goodies for you all who are here in person. And for those of you who are on the Facebook stream, if you're interested in having the same goodies that I'm going to be handing out to this group, this is a road show, so we go to different community locations and offer this program. So I hope to be invited to other churches or granges or schools around Rhode Island to do this program many times over the next year and a half. So that's one of our big goals. And I know I'm what's standing in the way of you in the weekend, so I'm going to be mindful of the time and try to go through the slides quickly, but I hope it'll be engaging, and I hope you have lots of questions for me. So what I'm going to be talking about is the Community First Responder Program, which is a grant that we received from SAMHSA, from the federal government, to create a research and outreach program to try to combat opioid-related breathing emergencies with a focus on rural communities. And this is a collaboration between the College of Pharmacy, myself, Diane Martins, who is a professor in the College of Nursing, and Deb Sheely, who is an associate dean in the College of the Environment and Life Sciences Cooperative Extension. So I don't have any direct conflicts of interest, but I do have grant funding to do this program, and in addition to that grant funding from SAMHSA, we did receive an anonymous donation to purchase some of the materials that we weren't able to purchase under the federal grant. So when you get asked to do a presentation the day before, you have to basically take a lot of presentations that you had in the hopper and put them all together. So this would not be possible without all the people listed in the left-hand column who have collaborated with me on many opioid and naloxone presentations over the past few years. So this is kind of a theirs, mine, and ours presentation because we have a mixture of everybody's slides. I don't know whose is whose, but they're all good, I think. So hopefully. All the people on the right side are really who is helping to make it possible for us to deliver this outreach program, to really get out into communities and distribute naloxone, to do the education. So they're really the boots on the ground who is helping us. And I want to say a special thank you to my student research team. I currently have 6 students who are actively out in the communities delivering these programs and doing naloxone distribution. So that has been really great, and it's been wonderful to watch them grow. They've really been key heart and soul of this project. So learning objectives, so we have 4, and I'm going to kind of, as I go through the presentation, draw you to what each one of these are. But we want to look at some data, some background, some legislation and state policy, identify who's at risk for an opioid-related breathing emergency. Look at naloxone and Narcan. You are going to be leaving here with a Narcan today, so that's part of what you're going to be getting. We're also going to be looking at harm reduction strategies, including fentanyl test strips, which we also will be distributing, and you can leave with here today. So starting out, so which of the following is true regarding Good Samaritan laws related to opioid overdose and naloxone? So federal laws offer immunity for criminal behavior. All 50 states have laws that offer protection from liability for complications related to resuscitation, or all 50 states have laws in place that offer protection from prosecution for drug possession or paraphernalia, or federal laws offer immunity from subsequent prosecution for drug possession. So those are the choices, and then we're going to review these at the end as well. So we have a split kind of between A, B, and C. I'm not sure how to know how long I stay on each slide. Lynn, do I just... Okay, all right, I wasn't sure. Which of the following statements about naloxone use is true? Since it's based off the structure of fentanyl, it's relatively ineffective for more potent fentanyl derivatives, such as carfentanil. In rural areas, increased access has resulted in the growth of Narcan parties. Locations with increased access policies have seen dramatic decreases in ER visits associated with opioid breathing emergencies, and pharmacists should advocate for physicians to take a leading role in co-prescribing naloxone to reduce stigma. So those are the different options. It looks like we have D is kind of out in the lead, and then B and C are in second place. And last polling question, which of the following best represents an effective communication method to discuss naloxone with a patient? Great work overcoming your drug habit. How about we talk about naloxone? Much like a fire extinguisher, naloxone is there in case of unforeseen emergencies. Your current medication regimen places you at high risk of experiencing an overdose. Naloxone is recommended. Or based on your total daily dose of opioids, government regulations suggest I speak with you about naloxone. So it looks like B and C are kind of popular. We got a couple of A's and D's. Okay, so to be continued. So drug overdose is currently the leading cause of death in people under the age of 50. So when we think about that, that's including motor vehicle accidents, fires, injury, falls, all of the things we think of causing death in younger people. And drug overdose is way out leading those other causes of death. Nationwide, prescription overdose deaths are responsible for about 40% of opioid-related deaths, and about 60% are due to illicit opioids. We'll look at some data for Rhode Island. We're a little different from that nationwide average, but that's what we see if we look at all 50 states. And we have seen a dramatic increase in heroin and fentanyl-related deaths, and we're going to talk more about that in the presentation. So if we break this down in Rhode Island, so this is overdose deaths by city and town. This is not city and town of residence, however. This is city and town for if someone from, say, Hopkinton traveled to Providence, experiences an overdose death in that area, that's captured in this data as a Providence overdose death. So you can see the green is, the light and dark green are lower numbers, and the orange and yellow is the more concentrated overdose deaths, which we do see more in urban areas versus the rural communities. However, this is a map that Amy Mandeville from CELS put together for us. So this is looking at city and town of residents. So when we look at city and town of residents, this is the percent change from 2009 to 2013. So from those 4 years compared with 2014 to 2019, we can see some differences here. So the higher rates of change are occurring in towns like Westerly, Charlestown, South Kingstown, Narragansett, the East Bay area, and Burrillville have high rates of change, so an increase in overdose deaths of greater than 100%, comparing those time periods. So those are the areas we're really focused on, is those more rural aspects of Rhode Island, and that's where we're trying to get out into those specific communities to do this active distribution of naloxone and education about the risk factors for experiencing an overdose. If we look at Rhode Island fatal overdoses, so if we compare 2009 to 2018, you can see there's a real change in the percent of illicit overdose deaths compared with prescription only. So about 62% back in 2009 is now down to 11% in 2018 for prescription-related overdose deaths alone. I do think there's a population of people that is not captured as much in this data, and that's our older adult population. So someone who is in their 70s and 80s and experiences an opioid-related breathing emergency, perhaps they've been on opioids for chronic pain for years, but then they have a respiratory illness, or they have Benadryl in the evening and maybe a cocktail or a glass of wine, and then have that breathing emergency during the nighttime. That is not captured as an overdose-related death. So we probably really don't have a good sense of prescription-related loss of quality years of life in the older adult population. So that's something we're really trying to educate people about, knowing what are the risk factors of combining medications with other sedating substances. So if we look at the waves and the rise of opioid overdose deaths, I was actually in Rhode Island and Miriam Hospital doing my residency back in 98 and 99. And I very well remember the drug reps coming to the units at that time, that was still allowed, and talking about the new wonder drug that had very low addiction potential. You guys probably know what I'm alluding to, which is OxyContin. And they had some rationale for this, and it was that because it's long-acting, you don't see the peaks and troughs that are associated with other substances of misuse, which is actually very reinforcing. I mean, certainly we think of nicotine, and you have a high peak and then a trough, and so you have cravings. So that seemed to be a rationale for this having a low addiction potential because it was long-acting. And we started to really increase prescribing, especially after trauma or surgical pain. We also were under a lot of pressure to achieve 0 pain scores for patients, or very low pain scores. It was considered unethical to allow people to have pain, even surrounding a major surgery. So we started to see this increase in prescription opioid prescribing and subsequently overdose deaths. And then in 2010, we began to see an exponential increase in heroin-related overdose deaths. And most of this is due to people crossing over from prescription opioids to heroin. It's very rare that you have a person who starts out with snorting or injecting heroin who does not have a previous exposure either to recreational prescription opioids or opioids prescribed for a legitimate medical purpose. So we started to see this because heroin is much cheaper and it's often more accessible for purchase illicitly. Then in about 2013, and certainly really going up in 2014, 2015, we began to see this increase in fentanyl-related deaths. Certainly fentanyl is something that we use therapeutically. We use it, long-acting fentanyl patches for people with cancer-related pain. That's not what this is referring to. This is illicitly manufactured fentanyl that's coming in from other sources, other countries. And it's being put into the drug supply to increase potency, but also to reduce bulk for trafficking. And you can see why it would reduce the bulk for trafficking, because these are equally potent doses. So these doses of heroin, or amounts of heroin compared to fentanyl, compared to carfentanil, which is a very, very potent elephant tranquilizer, these are all equivalent doses. You can also see they're all a white powder, they're all granular, they don't look any different, they don't have any different smell or taste or texture, so there really is no way for someone who is using any unregulated substance at all, so any substance that is not regulated and produced by pharmaceutical companies and gone through FDA testing, to know if there's fentanyl presence in that substance without testing that substance. You can't detect it in any other way. So I'm not going to get too into dopamine and all the different pathways, but we all are aware that dopamine is the pleasure hormone, but neurotransmitter, what we want to think about with opioids in the central nervous system is sort of what is the percent of people who, with exposure to opioids, will go on to misuse them. And I don't know about you, but I've taken, Percocet or Vicodin for pain. When I had my wisdom teeth out, years ago, they gave me a supply of Percocet, and I took one, and I felt like, Rip Van Winkle. I slept for, 12 hours. My mouth was dry. I felt kind of nauseous. I felt confused. I didn't know how the microwave worked anymore. It was this foreign thing that I didn't know how to operate, and I really didn't enjoy the experience. So it's kind of like, ugh, how do people, in my mind, I was thinking, how do people get, hooked on this, because it's just such an unpleasant experience. And that's true for about 75 to 80% of the population. They don't really experience a clear euphoria with exposure to opioids. But for 20 to 25% of the population, there is this sensation of euphoria, of slipping into a hot bath, of all the weight of the world being lifted from the person. And that percent of the population is vulnerable to going on to having opioid misuse. Of that percent of the population, about half will say, oh boy, I can see where this is headed. I don't want that stuff. Don't give me that stuff. I don't want opioids because, I liked them too much and I have a family member who had struggled with addiction and I don't want to go down that road. So they will sort of self-select, and it may have a lot to do with familial support and environment and the structure of that person's life and genetic factors we don't really understand. But for the other half, there may be a propensity to want more, to say, okay, that felt amazing, I want to feel like that again. And we don't have a good way of figuring out who falls into which group. So there's no screening tool that we can do to determine who's at higher risk of going on to misuse opioids a year later after having an initial exposure. And it can be a very, very short exposure that leads to eventual misuse. So I talked about some of this. People usually move from prescription opioids to heroin due to cost and access. The percent of people who are at risk for developing an opioid use disorder is potentially 20 to 25%, but in actuality, I said it's about half of that. So about 8 to 12% will really go on to develop an opioid use disorder. The driving factor for continuing opioid use disorder. So the first experience is that desire, that feeling of euphoria and pleasure. Starting to lose control over use, having to take larger and larger amounts due to the development of tolerance. So the receptors downregulate, people need more and more of the substance of the opioid to produce the same effect. They start to spend lots of time and effort and money thinking about where they're going to get their next opioid exposure. But then withdrawal. So withdrawal occurs when people have become dependent upon an opioid, physically dependent. It would happen even without psychological dependence. People who are not psychologically dependent on opioids but are taking them for pain, if we stop it suddenly, they will go through a physiologic withdrawal. And withdrawal is extremely unpleasant for people. Everything is running. Their eyes are running, their noses running, they're shivering, they're sweating, they have anxiety, muscle pain, they have diarrhea, nausea. It's been described to me as one of the worst experiences that a person can go through, much, much worse than the flu or the stomach bug combined. So this is a quote from the FDA commissioner. We know that the physical symptoms of opioid withdrawal can be one of the biggest barriers for patients seeking help and ultimately overcoming addiction. So we classically have done detox, where we get people pretty aggressively off of opioids. They experience that withdrawal, they go through that, and then they really never want to have that experience again, and it becomes a really big deterrent for seeking help in the future. So opioid use disorder cuts across all aspects of the population. It cuts across all races, ages, genders, ethnicities, but there are some vulnerable populations that may have higher rates of substance use disorder. So LGBTQ individuals, trauma victims, I'm going to talk about those two groups a little more, people from a lower socioeconomic position, racial ethnic minorities, concomitant mental health conditions, people who are homeless, and young adults and transition age youth are more likely to have recreational exposure to opioids, which is why we talk so much about keeping these medications out of the medicine cabinet, where they need to be locked up so that people who are in those teen years and young adulthood aren't experimenting with them recreationally. So we know in the LGBTQ population, there's higher rates of substance misuse broadly, so that includes tobacco, includes alcohol, and you can see here the last two bullets that there is almost double the number of LGBT youth who took prescription drugs without a doctor's prescription 1 or more times, and almost 5 times more who use heroin 1 or more times in their life. So this is a potentially high-risk group. Adverse childhood experiences. There was a speaker yesterday who talked about this. So having early 0 to 5 years of life experiences of abandonment, trauma, violence, there's lots of different factors, and they are additive, but they do lead to disrupted neurodevelopment, social, emotional, and cognitive impairment, and then potentially adoption of high-risk behaviors like substance misuse and experimentation. So this is something it's difficult to regulate. It's difficult to regulate someone's experience in the beginning of their life, but certainly social programs and economic programs, daycare, all the things that we can do as a society to bolster children really do make a difference in health outcomes later in life. So for the first learning objective, we're going to look at some strategies legislatively and statutorily aimed at reducing the growth of opioid-related disorders. So I'm going to focus on Rhode Island, but we can talk about nationwide strategies as well. So some ways that we have implemented to try to prevent opioid use disorder. So state prescribing laws, so trying to restrict the number of morphine milligram equivalents prescribed, the amounts of opioids that can be used for acute and chronic pain. Strategically using the prescription drug monitoring program to try to identify individuals who may be using multiple pharmacies or multiple providers to try to manage that. Formulary management and insurance programs, so trying to restrict the scope of prescribing. Academic detailing, so unlike the detailing we got for the OxyContin, this would be the opposite. This would be us going out and educating providers about prescribing practices and ways to reduce opioid exposure. Patient education on safe storage and disposal of prescription opioids. We've been doing a lot of that, having drop boxes, having places where people can take back the drugs at police stations and pharmacies, and just improving awareness and sharing resources about the risk of prescription opioids and the cost of overdose. So state laws in Rhode Island, I'm using us as an exemplar state. So for acute pain, we have initial prescribing limits. There's patient education and informed consent requirements. There's naloxone co-prescribing for high-risk groups, although you are starting to see it more ubiquitous where providers may just for any opioid prescription be co-prescribing naloxone. And we can talk more about sort of the pros and cons of that. In my opinion, every patient who's getting an opioid should be offered naloxone as an option. They don't have to have that filled, so if cost is a barrier and they identify it as being low risk, they do still have the right to refuse that prescription. It's not a mandatory that they take it home with them, but it does start a good conversation. And I have had success in talking to people who they themselves might not be at high risk, but they have someone in their home or who visits their home who is, who they suspect may have tried some of their medications. They want to have it there just in case teens or young adults or children in the home might accidentally have exposure or purposeful exposure. Patients can now ask for a partial fill of their C2 controlled substances, which is great. Certainly the time I shared that I had my wisdom teeth out and got Percocet, I think they gave me 30, and I took that one, and I didn't like it, but did I get rid of the other 29? I didn't. So my 18-year-old self held on to that. I wound up eventually it probably disintegrated and got thrown away. But I held on to it because I thought, well, what if I sprain my ankle running track? Maybe I'll just keep it, And people do think those things. And I had control over that medication. It was just there for me. Chronic pain. So we have written patient agreements. We have to examine the patient record periodically, consider referral to pain specialists when you get to higher morphine milligram equivalents per day. And then for all controlled substances in Rhode Island, we have to have providers review the PDMP. There's ICD-10 codes on the face of prescriptions. Now this is helpful for collecting data into the PDMP. It may be less helpful for community pharmacists in practice. I don't know if you're looking at an ICD-10 code. Do you have the ability to then look that up? You may know some of the common ones that you see more often, or you may get to know them, but and I think it would be helpful to also have like a written diagnosis so you can do that counseling kind of more quickly. And then electronic prescribing, which now is becoming more widespread with some exemptions for veterinarians because of not being able to get an NPI number. So the CDC has guidelines for chronic pain. I won't read all of these to you, but this is an important document that gives you information about trying to manage patients with chronic pain without opioids, and if opioids are prescribed, how to manage that the most appropriate way. If we look at the PDMP by state, you can see blue is states that require both prescribers and dispensers to check the PDMP. So that's 19 states, and then in 27 states, it's the prescribers only. And Rhode Island does fall into the green state. And then in 7 states that are highlighted in yellow, there's not a mandatory query of the PDMP. And Missouri in particular has been slow with PDMP adoption. It has been only by county. It hasn't sort of been statewide, so there are counties that have it, and that has been a slower adoption than the other 49 states. So for Good Samaritan laws, we don't have a federal Good Samaritan law. So each state has its own Good Samaritan law, and they really do differ in what is a covered protection under Good Sam. So in all 50 states, you are protected for resuscitative efforts that you do in good faith, trying to help someone who's either experiencing an overdose or any medical emergency. So if you were doing CPR and someone's ribs were broken, which is not, a super uncommon thing, you're not liable for that injury. If you're trying to help someone who experiences an overdose and they still have a bad outcome, you're not liable for that. In Rhode Island, that extends to other things, such as if you have drugs. So if you have drugs in your possession and you help someone who is overdosing and the police come, you won't be arrested for drug possession or other parole violations and things of that nature. That's true not in every single state. Vermont it is. Vermont has a very robust Good Samaritan law, but it's important that they do differ state by state. So this slide kind of shows the states in orange are the ones that have protection from probation or parole violations. Rhode Island is so tiny you can hardly see it, but it's the little orange sliver there. But then, about the same number of states do not have that. So people are reticent to call 911 if they are a person who uses drugs themselves and is helping someone who's experiencing an overdose because of fear of being arrested or having some sort of entanglement with law enforcement. So for our second learning objective, we're going to identify people who are at risk for opioid-related breathing emergencies, and this is true whether it's illicit opioids or prescription opioids for a legitimate medical reason. So people who have a history of substance use disorder are at higher risk. People who are taking opioids long-term for chronic pain are at higher risk. So your risk is not only when you first start out on opioids, but it continues. And actually long-acting formulations are higher risk, so the reverse of what we were being told in the late 90s for OxyContin, they're actually higher risk, and certainly higher doses of opioids as well increases the risk. Combining with substances that make you sedated, so this could be gabapentin, it could be a benzodiazepine, that's certainly a very, very high risk, and red flags should be going off, and there should definitely be co-prescribing and recommendations of Narcan for those individuals. But diphenhydramine, any sedating medication is increasing potentially the risk of a breathing emergency. People who have experienced an overdose in the past are at higher risk. People who have been abstinent for any period of time, maybe they were in rehab, maybe they were in a correctional facility, they now are being released back into the community and they have lost their tolerance. So the amount of opioids that they could previously take and feel fine, they now could take, and it could be a fatal amount for that same person, and that's due to that loss of tolerance. Certainly people who have respiratory conditions are at higher risk of having a breathing emergency. Sleep apnea is a big one, and that's a very common respiratory condition, COPD, asthma, but also people who have pneumonia or the flu, or maybe potentially now, we're having this respiratory virus, the COVID-19, we're unsure, is that going to potentially add to the rate of breathing emergencies in older adults who are taking opioids. So that's something to be mindful of. So when we're looking at our patients and assessing overdose risk, we want to certainly review their medications, ask about past substance use, check the PDMP, and ask patients if they've ever had a bad reaction to taking opioids. I find this is a lot easier than asking if they've had an overdose. People who are taking opioids for chronic pain don't really connect to the term overdose, but if you ask, have you ever had a bad reaction from this opioid or other opioids, you get a lot more information from the person. Have they ever witnessed an overdose, and do they have training on how to prevent, recognize, and respond to medication-related oversedation, or I like to say a breathing emergency? So if we want to make a dent in this overdose epidemic, this is a quote from the Surgeon General, we need everyone to consider themselves a first responder. We need to look at it the same way as we look at CPR, and we need everyone carrying naloxone. So with that being said, we're actually going to start distributing kits of Narcan to your table. So we have a group of students who's going to be bringing this around. And as that is happening, I'm going to continue to talk, and I'm going to walk you through some forms that I need you to fill out because it is a prescription. So I need to keep, appropriate records for that. All of the Narcan that you'll be receiving, because it has to be labeled with a prescription label, has my name as the patient. So this can't in any way be traced to you. It won't, impact your record if some people have had expressed concerns about things like life insurance, or, I have 2,000 doses now of Narcan with I don't think anybody's given me life insurance. So, sorry. So hopefully my husband doesn't want to bump me off because I'm not insurable. So there's several different formulations of naloxone that you're familiar with. What we are distributing is the Narcan single-dose nasal spray. So that's what you're going to be getting today. But there is a nasal spray that is a multi-step. And I'm going to talk about both. And then FZO is the auto-injector. There is also a vial and syringe. We usually don't do vial and syringe for community distribution unless it's with individuals who are comfortable with doing injections. So it may be appropriate for some patients. I've only had one experience of teaching a patient how to use the injectable, and it took a good 45 minutes before I felt she had to do that orange about 9 times before I felt like she could really do it. And to be honest, I wasn't 100% sure if under the stressful condition of an overdose, she would be able to. So it's quite hard for people who aren't experienced with using needles to actually do that. So most pharmacies and first responders are carrying the intranasal or the auto-injector, which the auto-injector has been very expensive in the $4,000 range. Kaleo is releasing a generic that I thought would be available in April, but that may not be true, but it's going to be more around $178 to $80, somewhere in that range. So it'll be a little more close to the price of the single-step nasal spray, but that isn't available commercially right now. So naloxone is the opioid overdose antidote, so it has a high affinity for the mu opioid receptors. It will literally knock opioids off of those receptors, which allows the person to regain consciousness, and it allows the breathing to be restored. So naloxone itself does not have side effects. So if I were to spray naloxone up my nose right now, I'm not a person who uses opioids, I wouldn't have side effects. I would have a wet nose. I might not enjoy the feeling of the mist being shot up my nose. It might be agitating, but it will not cause any side effects. It also won't really do anything. So if you give Narcan to someone who's experiencing any medical emergency that's not an opioid overdose, it won't harm them, but it also will not help them. So you still have to do all the usual things you would do for someone who is experiencing a medical emergency. So whether that be CPR, rescue breathing, if they have diabetes, giving them glucagon, whatever that might be, that would be in addition to this, if this was not actually what was causing the emergency. So in terms of how do you respond to someone who is experiencing an overdose? So the first thing is to evaluate, is this an overdose? So in an overdose situation, someone is not conscious. So if they are able to talk to you, but maybe they're confused or groggy or slurring their words, that is not the time to administer Narcan. is only given to individuals who are unconscious. So you can take the knuckles on your hand and rub it firmly on the person's breastbone while saying their name or saying, hey, you, if you don't know their name. That's moderately uncomfortable. And if they're not arousable to that, then that would be considered an appropriate time to administer naloxone. Typically, people also will have shallow or no breathing, but they may be breathing. It may be sort of a snoring or gurgled sound. And they may have a pulse because, again, this is a breathing-related emergency. So the impetus for giving Narcan is not just if they don't have a pulse. If they are not breathing and not responsive to you, or they're breathing slowly, you would go ahead and give the Narcan. Before you do that, you want to call 911. If you have two people, it's ideal to say, you call 911, I'm going to administer the Narcan and try to divide that up. If you're alone, call 911 first and then administer the naloxone. The administration of naloxone does not require the person to sniff. It's a nasal spray, but you're spraying it into their nostril, and they are unconscious. So you want to tilt the head back so that the liquid doesn't run out. You know, if you administer it when they're like this, the liquid might kind of run out. I have a little demonstration one here. I don't want you to open your boxes because you want to save that for if you are actually in an emergency situation. But I usually pass these around, but with all the restrictions, I didn't want to do that. But you put 2 fingers on either side of the nozzle and your thumb on the plunger, and it's literally just a 1 push. So it's 1 spray in 1 nostril, and then that's it for that. It's not reusable. If the person becomes responsive to you and starts breathing, you don't have to administer the second dose if they're, even if they're still groggy, but they're coming around. If they don't become responsive with that first dose and it's been 2 to 3 minutes, now that's going to be a long 2 to 3 minutes, I tell you what. Probably people don't realistically wait that long, which may be one of the reasons we see people getting 4 or 5 doses of Narcan is because people aren't waiting the 2 to 3 minutes in between doses. But regardless, the second dose would be administered in the other nostril, and it's done in the same way if the person is not conscious. In the meantime, you want to be supporting the person's ventilation, and that would be either with rescue breaths, or it could be, if they don't have a pulse, it could be chest compressions, it could be chest compressions plus rescue breaths. It would be commensurate with the person's level of comfort and training. One of the things that has really been deterring people from helping someone who's overdosing is fear of fentanyl getting on to the other person. So there has never been a confirmed case of passive exposure from fentanyl. There has never been a confirmed case. There has been some reports of people experiencing fainting episodes. It could be panic attack related. It could be some of it potentially personal drug use on the part of individuals responding to the scene. We're not sure. But if someone goes down in a panic attack, and if I got a white powder on me that I thought was going to kill me, I would have a panic attack too. So it's very understandable why that would happen. So if people go down in a panic attack and you spray a wet substance up their nose, they might come back. That's not evidence that they experienced. So fentanyl, as you know, as a powder is not pharmacokinetically absorbed through the skin. So that's not a risk. So you shouldn't be afraid that the person will get something on you and not administer help to that person. So how to use the Narcan nasal spray, I kind of walked through this. So you would remove it from the package. There are 2 in each box that you have. You don't want to remove it from the package until you're ready to use it. You can, however, remove it from the box. So I don't like to carry mine in the box because it's bulky. I take mine out and I put it in a Ziploc bag so that it can go through TSA and everything, and that's fine. They don't give you any problem with that. I put it in a Ziploc bag, and I put it with the little instruction card that you have in your kit that shows you how to respond to an overdose and how to recognize an overdose. And I'm going to grab mine so you can see what it looks like. So it looks like this. You could keep that right with the Narcan, because right now you all know how to recognize and respond to an overdose, but maybe in a year from now when you haven't had, it might be a little less clear, or maybe someone else in your family would need to use it. And so it's good to keep this little card with the Narcan. So tilt the person's head back, and then again, it's one-time use, and then you're done. So the other nasal spray is more complicated. The other nasal spray, you have to assemble. You have to assemble all the parts. You have to snap off the cap and the end. You have to take the cap off the vial, screw them together. It has to be threaded sort of together, and then a nasal atomizer attached. So you've got 4 to 5 steps in assembly. And I don't know about you, but if someone I care about is experiencing an overdose, my hands are going to be shaking. I'm going to be kind of freaking out. So this is going to be really challenging. So the single-step nasal spray is a lot easier to use and probably more friendly for people. So you all have a dose of Narcan. You also have a yellow sheet. So if you could please fill out the information from your Narcan with the yellow sheet, using the yellow sheet, and I do need to collect those. I need to keep them on file. You also have a sticker that needs to be placed anywhere on the yellow sheet. So this is the prescription information that you all have in your bag. I'd like you to stick a sticker that has an RX number, and it's in the upper right-hand column, or corner, not column, upper right-hand corner. Pick one of those white stickers and stick it anywhere on that yellow form. And that will show me what the RX number is. So it's this piece of paper. It's in your bag. You have an extra piece of paper, and this, if people could, some of the students could walk around and help people locate it. So it doesn't matter which one, anywhere on the yellow form, just stick it on there so that I have it. Any of the white stickers in the upper right-hand column. That's at the end. The RX number should be on that. Either one, that one or the one below it. There's a medium rectangle that looks like a prescription label, and then there's a smaller rectangle. So the smaller rectangle is fine, or the bigger rectangle. And it's on the patient information sheet. And then if you could fill out our current date and location, so Newport, and then today's the 13th, your city or town, your zip code, your gender, age, race, ethnicity, month, year it was distributed is March 2020. The number of doses distributed is 2. There's 2 in there. The lot number, so you can find the lot number in the black square on the top of the box. It should begin with the numbers 19, and it should be about 6 digits long. And then the expiration date should be either September or October of 2021. You may have, there's different lots and expirations, so it's in a black box on the end of on the top of the box. And then there's a spot for that sticker. And then as far as the type of activity, this is an educational seminar. So for those of you who are watching on the live feed who would like to have this happen, as I said, we are coming out to communities and can distribute Narcan. So we will collect those and keep them on file. They cannot be traced to you in any way. It's completely anonymous. It's just data for reporting to the Department of Health, so we know what cities and towns and what types of people demographically are getting Narcan, because we're trying to increase distribution. So I already talked about this. You can give rescue breathing, or you can do full CPR. If you revive someone and you have to leave them for any reason, you should put them in the recovery position. They will go into withdrawal from being given Narcan, and it is important if they start vomiting that they don't choke on the vomit. So rolling the person onto their side into the recovery position is important. So the person may start breathing, and that would be ideal, and become responsive. and then you don't have to give the second dose. The only time you have to give the second dose of Narcan is if they don't respond to the first dose and they are still continuing to be unconscious. And then you would continue to support their ventilation and give the second dose. So all of the formulations of Narcan are effective, and it's very effective in being given by lay people. We can see 75 to 100% of the time, naloxone administered by lay people is successful in reversing an overdose. Reports of aggression or combativeness after Narcan have been greatly exaggerated. Usually the person feels very yucky and they may say things verbally about being distressed because they're going through withdrawal or starting withdrawal, but not combative or harmful. So some frequently asked questions about Narcan. So you all have Narcan that expires in September, October of 2021, so you have about 18 months on that. Now, if it's December of 2021 and that's all, you still have that box, certainly we're going to administer it. It doesn't become toxic or harmful, it just loses potency. You can help to maintain the potency by not keeping this in your car. Your car experiences extremes of temperature, hot and cold. If you could keep this at as close to room temperature as possible, that would be ideal. What if you give too much Narcan? Well, that's not really something we worry about in the community. We worry about that more in the hospital with intravenous naloxone. If you give too much, you're just making the withdrawal much, much worse for that person. But in the community, you're giving the doses you need to bring that person back to feeling, to breathing and being conscious. What if you give naloxone and it's not an opioid overdose? Nothing bad will happen to the person, but then it won't benefit them either. So you need to still then switch gears and do the other things that the person needs. Does this enable heroin use? So we have good data that when we distribute naloxone into communities, the incidence of opioid-related breathing emergency visits to emergency rooms goes down and can go down by as much as 50%. So getting Narcan out into communities reduces opioid overdose visits to the emergency room. And there's no evidence of compensatory increase in heroin use. In fact, it appears to be a bit of a decrease, but definitely not an increase in communities where Narcan is being distributed. Where can you get it? You can certainly get it in any pharmacy. As you know, we have a standing order in all 50 states, and in Rhode Island, we have the benefit of mandatory insurance coverage. There may be a copay, however, and that copay, sometimes can be a barrier for people. So community programs like ours can be beneficial. And then is fentanyl resistant to naloxone? No, it is not resistant to naloxone. People sometimes give the doses of Narcan too fast, but sometimes people do need several doses, which is why it's important to call 911. Also, it only lasts 30 to 90 minutes, so the person can go back into an overdose experience. I'm going to skip over some of this because I know I'm been talking and we're getting close on time. So pharmacy distribution of naloxone, and this is pharmacy and community based, you can see that we have areas where there's been no naloxone distribution in 2019. So look at Foster Gloucester area and then Black Island. So I'm planning to spend July in Black Island at Ballard's distributing Narcan. That's my plan. So, but I would like to change this map. But also the other areas, so certainly looking at West Greenwich, Coventry, Hopkinton, into my Rhode Island geography is being put to the test here, but the East Bay area, there's Westerly, Charlestown, Richmond, all of those areas. So we'd like to see from our program more dark green on this map in those more rural communities. So what we're doing with our grant is sort of three big prongs of our program. So one is we have a website, and I hope you all will visit it because you can get more free CE credits there. We have 2 interactive programs that are live now, and you can use them. We will be building 4 more, so we will have a total of 6. I'm hoping to have them all up by September. That's my goal, but I don't know if I'm going to make it, but somewhere in there. But right now we have 1 law and 1 related to naloxone, and those are good for physicians and nurses and social workers and mental health counselors as well as pharmacists. We also have education for the general public, and I would love for you all to refer people to that. If you're dispensing Narcan to someone and you counsel them and you don't have a lot of time, you can send them to these modules. They're extremely interactive. They're almost like gaming. They're very short. They're only about 10 minutes each at the most, and they're written in lay language. They're very appropriate for teenagers, so schools could use them in health class as a way to educate, teens about opioids and Narcan. So this is something, it's all free and it's all live. Check it out. Help us spread the word. We also have embedded in the Narcan training that's online, we have state-by-state clickable links to information for all 50 states in the District of Columbia and Puerto Rico, with specific state-by-state information about Good Samaritan laws and Narcan distribution. And I just pulled a couple of states as examples. We also are going to be going to the South Kingstown Farmers Market every Saturday from 9 a.m. to 1 p.m., May to October, with the Mobile Health Unit. And the Mobile Health Unit has 2 private exam rooms that will be staffed with pharmacists and nurse practitioners. We'll be doing Narcan distribution, screenings for infectious diseases. We'll be giving out harm reduction supplies and referring people to treatment for substance use disorders. And then again, this training that you just had to be a community first responder, we can do in the community. We want to get out. I want to go to Burrillville. I want to go to Foster Gloucester. I want to go to Block Island. So invite me. So you can email us and we will go out. We can do small groups. I've done groups of 7 people. We can also do large groups. You guys are probably the largest one we've had so far. But you can email us to schedule once things have died down with the virus. So for the pharmacist role, I'm going to mostly focus on harm reduction for this because I think you've had a lot of education about using the PDMP and the laws. So syringe services program, there is a locator available online. It's nasin.org. You can help connect people to programs. Also, AIDS Care Ocean State does deliveries, so they can deliver needles and syringes and other harm reduction supplies. Fentanyl test strips. So you have some of those in your bag, and I'm going to show you a video of how they're used. As you saw from that slide, these are granules, white. They don't look any different from any other substance. So this is a strategy we use to help people who are still using illicit, like unregulated substances of any kind, to have the information of has it been contaminated with fentanyl. And I'll show you a video of how you use that. So we'll go to that right now.
So I'm going to give you this package of fentanyl test strips and all the components that you need. You don't have to open that one. I have one that's open here, so you can use this one to take home with you. But if you have time, I'd like to kind of go through all the steps on how to test substances for fentanyl. Fentanyl is a very powerful opioid that is responsible for a lot of overdose deaths. So we encourage testing all unregulated substances for the presence of fentanyl. So one of the first steps, this is a diagram that goes through the process that I'm about to talk about. Something that's really important is any substance that's going to be tested in this is a rinse cap here, needs to be very fine powder, so it needs to be broken down in order for the test to be accurate. So it can't contain any chunks. Any substance that's going to be tested should be in a fine powder. So you would place the fine powder in this rinse cap, and then from there we dilute the substance with water. And this ampule contains sterile water, so you would put the entire contents of the ampule into the rinse cap. Once the substance has been diluted, you want to take a fentanyl test strip out of the package here. And then you're going to hold this by the blue end. The part with the wavy lines goes into the water. So when I place this into the water that has the substance diluted, you hold it for 5 to 7 seconds, which is about how long it would take to sing the song Happy Birthday. When you remove this from the water, you can set it across the rinse cap. And the test takes about 5 to 10 minutes to get an accurate reading to see if there is fentanyl present in this substance. So I'm going to show you what it would look like after the 5 to 10 minutes. If the result is negative, you would see 2 red lines appear here on the test strip.
Okay.
If the result is in fact positive and the substance does contain fentanyl, you would see a single red line on the test strip. If the result is positive for fentanyl, that means that it's potentially dangerous for use. The safest thing is not to use the substance. But if someone chooses to use the substance, they should use about 1/4 of the amount that they would normally use or less. It's always possible to use more if needed, but it's impossible to use less once it's been consumed. So we advocate for, if you do have a positive result with 1 line, to use a very small amount or consider not using the substance at all. So I know this is a lot of information that I went over. If you have questions or want more information, more details about how to test substances, you can contact the local harm reduction organization or the syringe services program, and they can go through it in a lot more detail than I was able to do here today. Another thing that I want to mention is any substance that's been tested with a fentanyl test strip should then be discarded from the rinse cap. It's not safe to be used or injected once it's come in contact with this strip. It basically makes it bad.
Okay.
The other thing that I'd like to give to you is this kit is to test unregulated substances, but there are information in here about methadone and buprenorphine, which are safe to use. You don't need to use fentanyl test strips with methadone or buprenorphine. So if that's something you're interested in, we have information here. We also have information on safe needle disposal and naloxone, which you have to take home with you today. So I'd like to give that to you as well. Do you have any questions about this process? Like I said, I know I've given you a lot of information.
All right, in the interest of time, I'm going to cut that there. But you can see, from that, some important things are the fine powder. So it has to be a fine powder. And the other thing is you're not testing something that you're then using. So it's the residual. So somebody would draw up their shot or separate what they're going to be using, however they're using it, and only test a very, very small amount of substance. And again, the goal of this is to keep people alive so they can get into treatment and recovery with methadone or buprenorphine or whatever the appropriate therapy would be for that person. So you all have 10 fentanyl test strips in your bag, as well as instructions on how to use them. If it's not something that you need, you may know someone who has a family member who's struggling with substance use disorder, so you can certainly give these to someone else. I also have a box with many more, so if some of you know someone who has a family member who's struggling with addiction and would like more of these until they can get into recovery, I'm happy to give you more, because 10 is just a small amount. So there's lots of different difficult conversations that we wind up having as pharmacists. So people who come in for syringe purchases and you're offering naloxone, that can be a difficult conversation. I try to keep it, we don't need to know why. We don't need to ask, what are the syringes for? I just talked in that entire video about substances. I never even used the word drugs, and I tried not to imply that he was the person who was using anything. So it's all just general, and just trying to have these conversations about what is the safe, what is the best recommended practice, what can we do to get people towards recovery without having to dig down into details, because people who use drugs are very hesitant to share the details of that information. The other thing that we need to reframe is some of our conversations that are challenging surrounding prescription opioids. So telling people that we don't have their medication can really precipitate a combative relationship with the patient because they have developed dependence. They are very fearful of going through withdrawal. So withdrawal is really that when you have someone who is panicking and becoming aggressive, it is fear of withdrawal that is usually driving that. So when you've identified something in the PDMP or you have some reason why you can't refill an opioid for someone, it's really important to let them know, we recognize that you need something to help you, and we can talk about different alternatives, ways to get you safe and get you comfortable. So we want to, instead of pushing people out into the community where then they might turn to heroin, fentanyl, other illicit substances, we want to try to mitigate that risk. And I'm hopeful that someday we'll have much more low barrier access to buprenorphine so that people who are, scared and needing it can get it much more quickly, maybe even from pharmacists. That may be something that we want to do in the future, and I'm hopeful that we do. So talking to people, motivational interviewing, you can take whole courses on it. I have, it's amazing, but it comes down to 3 things. RIC, so rapport, importance, and confidence. So the rapport you have with the patient, never, discrediting them or creating embarrassment, validating their concerns. Importance, every human being wants to know what's going on with them, from someone who has a very low IQ to someone who is a genius. Everybody wants to make sense of what's happening, so we can educate them and really explain it in detail. And I do use certain terms. I say bad reaction to opioids or breathing emergency. If it's someone who injects drugs, I do say overdose because they're more comfortable with that. But with prescription opioids, I tend to shy away from that terminology. And then confidence. Sometimes people will say, well, I want this, but I'm doing this, and they're kind of at an impasse, and you have to help them find their own solutions. And sometimes that's where harm reduction, maybe they're not ready yet, but you can give them that confidence to get there. So we're used to supporting people's culture. We spend a lot of times talking about religious and ethnic beliefs and use of medication. But with drug culture, we actually do need to kind of weaken people's connection to communities that are sabotaging their efforts at recovery. So these are different ways of kind of looking at that, but we want to help connect people to new environments and sort of strengthen what's around them. We also want to avoid re-traumatizing people. So people who've been traumatized, we want to realize that people with substance use disorder often have a trauma history. We just want to respond in ways that don't re-traumatize them. And that a lot of that comes down to having negative adversarial interactions with healthcare providers. So the more we can avoid that, the better. When we look at methadone and buprenorphine, there's often this big concern that they're being buprenorphine's being diverted and shared, and that may be true. When we look at reasons for illicit buprenorphine use, it is very, very rarely to get high. So as you know, it's a partial agonist. So this is mostly what people are doing to self-medicate for cravings and withdrawal. So again, low barrier buprenorphine would allow people to get this that they need to stay out of withdrawal and manage pain or anxiety in a healthier way, a safer way than turning to illicit substances. And similarly with methadone, the primary reason for diversion of methadone is related to trying to help someone else or help themselves if they had a missed appointment due to various reasons or missed the prescription pickup. And I know the speaker yesterday talked about a lot of waiting in line and difficulty with accessing methadone. I think that could be loosened. Okay, so we'll get to the questions. So which of the following is true regarding Good Samaritan laws related to opioid overdose and naloxone? So this is the poll everywhere. All right, so all 50 states have laws that offer protection for resuscitation efforts, but not all of them do have for other things. So it would be ideal actually to have a federal Good Samaritan law that offered more widespread protection. We would see more people calling 911. For people who revive someone with Narcan, we only see them calling 911 about half the time. So half the time that's not happening. But if they give naloxone and they don't call 911 and they, split for whatever reason because of fear of prosecution, people do well. So that actually is successful in saving a lot of lives. Which of the following statements about naloxone is true, naloxone use? All right, so that was quick. So definitely it has been shown when we get naloxone out into communities, it reduces emergency room visits by about 50%. And we want pharmacists to be distributing it. We want it to be like, when you get your opioids, you get your Narcan. Just like when you get a hamburger, they always ask you if you want fries. We want it to be that unstigmatized. And then which of the following best represents an effective communication method to discuss naloxone with a patient? So I like B, much like a fire extinguisher, naloxone is there in case of an unforeseen emergency. So it's not putting any blame, it's not assigning any specific suspicion related to misuse of opioids. And a fire extinguisher is not stigmatized. You wouldn't walk into someone's home and see a fire extinguisher and think they were playing with matches or setting the curtains on fire. So it's just a safety measure like any other one. And we do have a post-seminar survey that's on your table. It's on a purple form, and if you can complete that for us, that's part of our grant, is to collect that data about satisfaction with the program and some demographic data that SAMHSA has asked us to collect. And we can also take questions. And for those online who would like to complete the survey, there's a QR code and a link. So for those of you watching online, you can still participate in that part. And as I said, if you'd like to have a training with Narcan distribution in your town in Rhode Island, I can go to any rural town, and they've been generous, and basically I just have to stay out of like Cranston, Warwick, Providence kind of areas, but that whole western side and East Bay side and southern side is accessible for us. So we're taking this on the road. And I think Jen's going to help me with the questions and then the code.
And then once we're done, you can just go on to the next slide for the code.
Hi, so there was a question about if everybody in this room is eligible to receive the Narcan and the fentanyl test strips regardless of background or where they come from.
Yes, so there's no age restriction. So anybody, under 18, there's no, age restriction related to naloxone, being distributed. And fentanyl test strips, it's not a prescription item at all. It's just a for sale item.
Thank you.
And they're about, if you were to purchase them, they're a little more than $1 per strip. So, they're could be costly if someone's using a lot of them. So how to use the PDMP. So this is for healthcare professionals, pharmacists. So it's very easy to register to access the PDMP if you're a healthcare provider. But for lay individuals, that it's not accessible. So it's really, for pharmacists, for prescribers, ancillary staff may have some access to it in a provider's office, but it really is meant to be for healthcare professionals. Okay, if we are from out of state to take an naloxone kit, yes, so this is for distribution. So I am the recipient of it technically, with my name being as the patient. So where it goes from here, you can travel with it. You could potentially, give it to someone else. It's not a controlled substance, so that that's up to where you want it to go. And then posting the slides, I'm assuming they'll be posted. Okay. So yes, I am happy to have people come to URI to pick up Narcan kits. So if you've done the training online and you want to come in, I'll have you fill out the yellow form and then distribute the Narcan with just sort of a basic counseling. Same thing with people who do the online training. So there's a CE Narcan program online. If you do that and then want to come in and pick up at URI Kingston campus, that can be arranged. No problem. And also, as I said, we'd like to get out into communities. We'd really like to get to younger individuals, into high schools, and teens. So test kits are considered drug paraphernalia at URI. Any plans on changing that and perhaps having it available at RA offices? So I don't know what the policy is with RAs, but fentanyl test strips are decriminalized in Rhode Island. So having them is not like there's no criminal aspect of having fentanyl test strips. And I know that URI historically hasn't had Narcan or other things in all of the dorms, but it is okay for individuals to have it. So if they have Narcan in their dorm room or something, that's definitely not a prohibited thing. But they haven't, installed it in every dorm or RA office as of this point. So for someone who wants to get Narcan who's not having a training, you can go to any pharmacy. Now you may have a copay associated with that. So for the free Narcan distribution, that's usually more a community program. But in a pharmacy, there may be a copay, although state programs, there may be a zero copay. So it just depends on the plan, the extent of the coverage. And that's true in all 50 states. And as I said, on our online version, we have a state-by-state resource. It's on the one for the general public. You can go and you can look at